to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hello, everybody. I'm Paul Stacks, Clinical Director of the Division of Infectious Diseases at Brigham and Women's Hospital and Professor of Medicine at Harvard Medical School. Welcome to Clinical Clips from the 2024 AIDS Conference, and this is day 2 of 4. First up is arguably the most highly anticipated presentation at the conference, and this is the Purpose 1 trial of long-acting lenacapavir given as an injection every 6 months as pre-exposure prophylaxis. And it's compared to 2 oral options, the standard of TDF-FTC as well as TAF-FTC, and it's conducted in women in South Africa and Uganda, women who are at high risk of HIV because of the high community prevalence of HIV. So the study design is straightforward. It is a blinded trial with about 2,000 women randomized to lenacapavir, about 2,000 to TAF-FTC, and about 1,000 to TDF-FTC. And the way that they estimated the background incidence of the HIV infection was they used the women who screened for the trial and were found to be HIV positive, and then used something called a recency assay to estimate the incidence. There was no placebo arm in the trial because it would have been unethical to do that. And the primary analysis was lenacapavir versus the background HIV incidence, as well as FTAF or tenofovir TAF-FTC versus the background incidence. And then there were secondary analyses looking at lenacapavir versus TDF-FTC, as well as TDF-FTC versus TAF-FTC. So that's kind of the study design. And let me just tell you the patient population, because it's important. The median age was only 21, and there were participants as young as 16. And at baseline, over 20% had a bacterial sexually transmitted infection. The most common was chlamydia. And the groups were well balanced. And as I said, it was a blinded trial, so they didn't know what they were receiving. And then we heard the news in June that the External Data Safety Monitoring Board stopped the study because of the exceptional protective effect of lenacapavir. And this is the key slide, which showed that there were 0 cases of HIV acquired in the lenacapavir arm versus there were 39 infections in the TAF-FTC arm, and there were 16 infections. Remember, there's only half as many people randomized in the TDF-FTC arm. So this is astounding. And of course, this is statistically significantly better than the background incidence, which was 2.41 per 100 person years for the estimated background incidence. And so lenacapavir was significantly better than the background incidence, and it was significantly better than TDF-FTC. And then the other comparisons did not show protection. The TAF-FTC did not show significant protection over the background incidence, but not surprisingly, based on our previous studies where it doesn't seem to work as well in certain populations, the adherence to the oral therapy was very poor. So the drugs were well tolerated. The lenacapavir was associated with some injection site reactions and nodules, but these were not sufficiently bothersome to have people drop out of the study. And there were no other, remarkable safety events reported. In people who were more adherent to TAF-FTC, they did show a protective effect. That was it was an association with protection. That was a sort of post hoc case control study. But overall, the big news is the lenacapavir. And I just want to mention that there was a second study ongoing in men who have sex with men and trans women who are at high risk for HIV, looking at lenacapavir versus oral therapy. And that study is expected to have results by the end of this year or early next year. And at that point, lenacapavir can be filed for approval for pre-exposure prophylaxis. Big challenge will be implementation. We learned yesterday's clinical clips that cabotegravir, even though significantly better than TDF-FTC, the use of it is not very widespread, at least in the United States, and this is almost certainly because of the implementation challenges, and that will be a big challenge for lenacapavir. In addition, this is currently an approved drug for HIV treatment, which is quite costly, and the makers of lenacapavir have committed to making it available in the parts of the world that are hardest hit by the HIV pandemic. But very exciting news. I want to say being there today while Linda Gale-Becker presented it, and there was a standing ovation at the end of her presentation, and there was spontaneous applause when the zero incidence result was announced. So one other comment about this lenacapavir study, I just want to mention the biggest challenge in HIV research in some ways has been HIV vaccine research. And this result really will put additional challenge on HIV vaccine research, because if you think about it, if there's a background pre-exposure prophylaxis that's all but 100% effective, then really that this makes finding an effective vaccine even more challenging, because obviously the sample size would be absolutely monstrous to show better protection than this. Another challenge in HIV research is HIV cure. And all of our successful HIV cures, and I'll put it in quotes because everybody is sort of hoping that they don't rebound, have been people who've undergone stem cell transplants. And so this is a case report of, quote, the next Berlin patient. This is another patient from Berlin. He's a man who was born in 1964, and he did not have CCR5 delta 32 homozygous donor. In fact, he developed leukemia in 2015, and he had a donor who was CCR5 heterozygous, so had one wild type gene and one delta 32 gene. He then received reduced intensity conditioning, and then after his stem cell transplant, he had some acute graft versus host disease, and he was, successfully transplanted, and that was in 2015 or so, 2015, 2016, and then on his own in 2018, he elected to stop his antiretroviral therapy. He did not experience virologic rebound and has since undergone extensive investigations, including looking for HIV DNA in his cells, none found, looking for HIV RNA and DNA in biopsies from his GI tract, none found. He had outgrowth assays, which were unsuccessful in recovering any virus. And in addition, as has been seen in other HIV cure cases, his HIV immune responses are fading. So his HIV antibody titers and his cellular immune responses are fading. So he has now been off treatment since 2018 with no virologic rebound. He does look like he is yet another one of these cases of HIV cure with stem cell transplant. The interesting thing is that it was not a donor who was homozygous for delta 32. It was heterozygous. So this adds to an additional case showing that perhaps there's something about the immunity transferred in the new stem cells that is fighting off HIV in addition to the reduction of the viral reservoir. So stay tuned in this area. It's obviously not scalable in a big way, but it is still exciting whenever one of these cancers is so well described as it was here. I'm going to mention a couple of other studies real quickly. One is in the DoxyVax study of post-exposure prophylaxis with doxycycline. With doxycycline, the group reported the incidence of antimicrobial resistance in participants in that trial, in particular looking at gonorrhea. And what they found, which was reassuring, was that doxycycline post-exposure prophylaxis did not select for ceftriaxone resistance. That's good news. And in addition, it did not appear to select for resistance to ciprofloxacin or to azithromycin. Sometimes antibiotics can cause cross-resistance in other drug classes, but that wasn't the case here. What doxycycline post-exposure prophylaxis did do, not surprisingly, was it enhanced the resistance that was already present of gonorrhea to doxycycline. So by the end of the study, there was actually high-level resistance to doxycycline. And I think that we're going to actually probably see a reduction in the effectiveness in doxycycline over time for gonorrhea protection. Already it's less effective in protecting against gonorrhea than it is against syphilis and chlamydia. Now, the last study I want to cover is one called SOLAR 3D. This has been presented previously, and this is an evaluation of using dolutegravir lamivudine in people who have the M184V mutation or not. And let me describe the study design because I think it's important that we understand both what it's showing and its limitations. So in a single clinical practice, 50 patients with M184V mutations, so resistance to lamivudine and emtricitabine, were recruited, and 50 patients without M184V were recruited, and all of them were very treatment experienced. They had virologic failures, but they were currently virologically suppressed. That's the key thing. And the group with M184V, in fact, were virologically suppressed for over a decade, and some of them were suppressed on abacavir, lamivudine, dolutegravir. And then the intervention was that all 150 and 50 were switched to dolutegravir lamivudine, and now we know at week 144 that they have maintained viral suppression. So this study tells us that there is certainly a subset of people with long-term viral suppression who can be successfully treated with this strategy, even if they harbor 184V. The problem is that it's just a small sample. It's just 50 patients. And so I don't think we should generalize more broadly to be using dolutegravir lamivudine in this context. And what that would require is a fully powered randomized clinical trial of people with 184V, randomizing them to either go on dolutegravir lamivudine or stay in their suppressive regimen and do a formal statistical analysis. That was not the case here. This is really an observational study, and it should not be used to guide broad clinical practice. So thank you for joining us for day 2 of Clinical Clips. Please refer to the landing page for slides and to claim your continuing education credit. And also come back tomorrow for our 3rd clinical clip from the 2024 AIDS conference here in Munich. Thanks so much.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.